I have nothing really to disclose in terms of financial issues. I do want to mention that I don't know if anybody is old enough to remember Joe Cocker, the rock and roll singer, but he was always famous for doing very spastic things while he was singing. He always got contorted. So I just want to mention that in parallel, if you see me starting to get contorted during the middle of this talk, it's because there's a fly that's really annoying me. And I've been trying to get it the entire afternoon. And it's really, even my dog, who's a super fly catcher, even he can't get this bugger. So like I say, if you start seeing me swatting things, that's not because I'm spazzing out, it's because I'm trying to get this fly. Okay, so with that disclosure, today we're going to talk about this, one of the major geriatric syndromes of frailty. And our objectives today are to understand why frailty is considered a clinical syndrome as maybe opposed to a disease. And we want to talk about the clinical manifestations of frailty. We want to talk about the adverse events associated with frailty and also methods for preventing frailty, as well as structured assessments, and then opportunities for optimizing management. Okay, next slide, please. So the topics we want to cover are the different reasons that frailty may come about. Want to talk about how to assess it, how to manage it, how to prevent it, and then compare frailty to failure to thrive syndrome, which are somewhat overlapping conditions. And then talk about the interventions such as palliative and hospice care related to frailty, which we often don't think about. Next slide, please. So what I'd like you to do is in the chat box is to write your definition of frailty that could be used by a clinician, let's say a primary care doctor, who would say that when they saw the patient walk into their clinic, that this person is frail. And then in this concept, if you could use at least 5, well, you don't have to use 5, but up to 5 signs or symptoms in your definition. So go ahead and just do that in the chat box. We'll give you a couple of minutes here to formulate your thoughts and to put in your definitions there. Okay, so we got out of the box here. So it's like a race course here, horse racing. Diana says weight loss, weakness, and difficulty walking. Thank you. Yeah, fatigue is another one. Thin skin. Yeah, Dawn's saying thin skin's smaller stature. Yeah, looking weak. It's good. I like the fact that everybody's putting in fatigue. That sounds like we're coming to a consensus here pretty rapidly. Yeah, functional impairments. Interesting malnourishment. That could definitely be part of that. Brittany says delicate. I like that. Yeah, and then Lindsay Clement talks about decreased functional mobility, thinning hair. Oh, good gracious! We'll talk about that. Graying hair. You know, when I turned 40, my hair turned the way you see it now, and I blame that on my 3 daughters, who were quite young at the time. But each side of my scalp got gray from each daughter progressively. Yeah, so good. Somebody, Jim points out gait issues, an assistive device, and falls. Great. Well, we'll keep an eye on all these, and I think these are very good examples of our collective wisdom about what frailty consists of. Now, importantly, is that a lot of the definitions that people came up with, or the descriptors, are just slightly a little bit different from each other, and that's good. But it's also, as you can imagine, from a research point of view, is to try to come up with a robust, definitive definition is always a point of discussion. I sit on study sections where we review grants from different researchers, and boy, oh boy, do they get into a dialogue, you know, these grant reviewers about is frailty associated with dementia or not? And, the question is, well, yeah, it can be, but it also can be associated without dementia. So, it just becomes a little bit of a dog chasing its tail kind of concept. But I think it's important to point out that even amongst ourselves, that we do have some variation in definitions for whom we would recognize as being frail, should we see them in the clinic. Okay, next. So well done. Thank you for that input. So in defining frailty, firstly, it is an age-related syndrome. Okay, so it's correlated with age. It's associated with decreased physiologic reserve. So these people are more susceptible to different stressors, whether those stressors be something like COVID or influenza. Other stressors, such as low blood pressure, might also, or ischemic events. They don't have a high survival rate when faced with these different types of stressors. It constitutes multiple symptoms, and I think we had a very good list of that, indicating weakness and fatigue is highly representative of these individuals. And ultimately, we have to understand that there's adverse events, and so we had Carpagan mention in the chat box about adverse events such as falls. So yeah, definitely falls and accidents, they're more prone to injury as a result of that, and a higher mortality. So it's a big deal in terms of identifying frailty of the older adults. I think we'll talk a little bit about in the epidemiology is that about 15% of the older adult population over the age of 65 have some elements of frailty. And so by definition, we use that to identify a patient population that would be or would potentially benefit from geriatric consultations. So I just want to keep have that in mind, not to self-promote, but we do have a geriatric assessment clinic in Sanford, Fargo. And so if you ever need to have a referral for frailty or geriatric assessment, that can be done through my clinic. Next slide, please. So some of the core concepts about frailty is that what are these stressors? Well, certainly a heat wave and cold waves. That's why there's such a high mortality rate, particularly during heat waves. I don't know if you recall, but in France, maybe about 10 years ago, everybody goes in August down to the Mediterranean, but they leave grandma and grandpa back in Paris. And so it turned out that there's not a lot of air conditioning there. And a lot of folks came back to their homes in Paris and found granny and grandpa deceased from heat stroke. Because there was a massive over 100 temperature consecutive for over 14 days that people were exposed to. And then also the other stressors are infections, trauma, obviously, whether they be anything ranging from auto accidents to falls. And then also just the simple hospitalization. These frail people don't do well. And so that's an important consideration. And equally importantly is surgery. So if you have some form of frailty and you've got somebody coming in and say, I want clearance for my surgery to get my hip replaced, you kind of have to ask yourself, if they're frail, is, what the likelihood is that they're going to be able to recover or even benefit from that. So that leads to the following points in the blower box there, that they have delayed recoveries. They have progressive, and this is important, their trajectory is progressively increasing functional impairment, and then also planning for dependency and isolation, and eventually death. And I think a lot of people just don't really think in terms of frailty as being having a less than 6-month prognosis with advanced frailty. Next slide, please. So here's a big difference, right? If you're a hospital-based practice, you can predict age for one, and previous history of delirium from hospitalization is associated with a high reoccurrence of delirium or acute confusional states. But if you identify somebody that's frail coming into the hospital, they've got a 50-50 chance of manifesting delirium at some point in their hospitalization. And it's equal whether it's in the beginning, middle, or end of the hospitalization. And then we have instances where hospitalists, regrettably, are prescribing delirium-inducing medications like Benadryl and other anticholinergic medications that additively predispose the older adult to delirium. So that's the connection between frailty and mental status changes. Next slide, please. So this is a little bit of a cartoonish graph. It's kind of a paradigm that was adapted, or I've adapted it from this publication from quite a few years ago, but it does show on that dotted line the kind of the cut point, if you will, of high function or reasonable functionality. And then below that dotted line is permanent disability. And so one of the goals in geriatrics is to keep the older adult above that dotted line at whatever costs possible, because once they hit permanent disability, you can see that orange graph there showing somewhat of an exponential decline or trajectory towards eventual failure to thrive in death. Next slide, please. So this is just a conceptual framework. You know, if you think about somebody that comes in on the left here with 100% functional abilities versus those in the other lower lines that have some functional impairment, you can see the trajectory here. So that the top line is basically an individual that is 100% functioning. They end up in the hospital, let's say, and they lose their function, however you want to measure it, and then they recover. The next line, the middle line, you've got somebody with a lower function. Let's say that they've got 75% of their function. They get sick, whatever the stressor is, and they lose their function, and they kind of slowly get back, possibly back to their original function. But the vast majority of people do not regain their function. So if you have one impairment and leave the hospital, there's a 60% chance generally that you're going to have another impairment. And that's represented by this lower graph here, where again, the stressor occurs, they lose their functional ability, they're dependent in transfers, they may be dependent in grooming and bathing, and they only get maybe halfway to 25% of where they were previously, and they never recover. So those are the three representations of recovery, partial recovery, and lower recovery that you need to consider in this population. Next slide, please. Oh, and I would just add, with that previous slide was the concept of post-COVID syndrome. You know, so how does that impact, you know, functional recovery? So this slide shows, I think, a very pictorial and a good way to basically describe or consider frailty. Sorry, my Apple Watch was just talking to me for no good reason. So now I got to fight an Apple Watch and flies in my presentation here. Sorry about that. So in the frailty continuum, you can see to the left there, the very fit jogger, walker, going to somebody that's a little slower. And you can see that people are increasingly becoming more slow in their gait speed. And that's an important consideration. So somebody that has 0.8 meters per second or less gait speed could be considered near frail or potentially frail. So just simply using gait speed can be highly predictive of their frailty and their level of frailty. Obviously, the slower they are, the more likely they are to be severely, moderately to severely frail. Next slide, please. So in terms of the different phases of frailty, in its most end stage component, it is thought to be irreversible. It's usually a pre-death phase, and it has an incredibly high 12-month, if not a 6-month mortality. By contrast, the earlier phases of frailty, once identified, can be responsive to treatment. And so there's a study out of University of Chicago that shows fundamentally that 30 to 40% of these so-called pre-frail or intermediate frail. There's different definitions of these individuals, that it can be reversed, which is wonderful news, and it is even more importantly with that information to understand and be able to recognize these pre-frail syndromes. Next slide, please. So there's frailty due to what we call primary or intrinsic aging processes. These often are, if you can imagine, the 110-year-old who, despite making it to over a century in lifespan, still have the dwindles in the final 2 to 3 years of life. The other component of frailty is considered secondary frailty, and these are typically associated with end-stage chronic conditions, frailty associated, for instance, with advanced congestive heart failure, end-stage COPD, that would be called gold class 3 or gold class 4, COPD, end-stage renal disease. There's basically 18 months average life expectancy for older adults on hemodialysis, for example. Next slide. So one of the questions really is that if we're going to try to predict who's going to become frail, how would you do that? So let's go to the next slide. So one way is to just identify the number of chronic conditions, and this is all associated with what we call multi-system dysregulation. So if somebody has high blood pressure, diabetes, COPD, diastolic heart failure, if they have 5 and osteoarthritis, let's say, that person is destined for frailty. And so there's really a compelling reason to address that early on, even if though they're independent in their ADLs and IADLs, you still want to address these chronic condition individuals in anticipation that they're going to have a sliding trajectory, functional trajectory downwards. Next slide, please. So the things that we look at are obviously strength and balance. It turns out that balance is a pretty good link, or lack of balance, I should say. Motor processing, just what I call psychomotor slowing, can be associated with frailty. Nutritional considerations. A lot of times people don't realize that as we get older, we need more protein. You actually need 1.2 grams per kilogram of protein, as opposed to the more usual younger 0.8 to 1.0 grams per kilogram of protein daily. Lower endurance, right? So people can't keep up with what they used to do. They might have lower physical activity. So that's an important consideration. We talked about mobility, right? So the slower the gait speed, the more predictive that is of frailty, of the frail condition. And then plus or minus cognition, right? So some of these people might have minimum cognitive impairment, MCI, or they might have frank evidence of Alzheimer's or some similar cognitive impairments, other dementias. Next slide. So this is comes out of Linda Fried and the Johns Hopkins group, who look at this whole question of cycle of frailty. So from a very physiologic, biologic point of view, you've got these different conditions. So if we start at the top, you can see that there are chronic undernutrition. And we're finding out more and more about our diets and how they might play an important role in the aging process. So you may have heard me say this before, that in the immune system, they've discovered that the T cells are defective with age in what's called one carbon chain metabolism. And so that's, we're not getting enough glycine in our diets. And so therefore ramping up glycine through dietary additions like legumes. And so any type of beans, edamame, are high sources of glycine as well as protein. So that would be an important consideration for nutrition and aging. But by the same token, On the right side here, we can see sarcopenia and weight loss. So 5% weight loss over 3 months, and sarcopenia where you have muscle wasting and loss of strength. All this could be due to a variety of things. So it could be due to medications where, the rivastigmine or some other acetylcholinesterase inhibitor, Aricept, might be causing gastric distress or gastritis. Maybe the diabetes is causing abdominal distension or stomach atrophy or stasis, right? And so that could decrease absorption, it could decrease appetite, early satiation, all leading to a variety of things such as hyperglycemia and loss of strength. As you can see in the lower right-hand corner here, that loss of strength and power then leads to what we talked about earlier with falls and injuries. It leads to more immobility, and so the immobility causes even more deconditioning. And you can see each of these cycle around, feeding off of one another to create this phenomenon that we call frailty. Next slide, please. So even in the intensive care unit, there's a frailty syndrome. They call it ICU frailty. It's this cycle of chronic malnutrition, loss of muscle mass called sarcopenia. There's a decreased metabolic rate, so you don't metabolize things properly, and overall reduced energy expenditure. And then the body compensates for itself by saying, hey, we don't need that much energy because this person's not moving around so much. So all those enzymatic pathways and metabolic pathways start to decline, and you become more hyperglycemic. The high glucose attaches to proteins, that causes more damage, more weakness, and fatigue. So people say, why do I feel fatigued? A lot of this can be associated with this cycle. Next slide. So as we talk about these different characteristics, we look for frailty criteria, such as weight loss, greater than 10 pounds of unintentional weight loss from the previous year. People will talk about exhaustion. They'll talk about weakness, and weakness can actually be physiologically measured with grip strength. And also they have low activity levels. They expend less than 270 calories per week. As I look at my Apple Watch, it tells me how many calories per day that I average, for my physical activities. And it tells me I'm not doing enough. So I guess I got to ramp it up a little bit here. And then also slowness, right? So we remember we talked about gait speed, less than 1 meter per second. I mean, this one talks about feet per second, but the common use now is meters per second. So, and it's a simpler number to remember. 1 meter per second or less is considered associated with frailty. It's also a predictor of falls, by the way, even without frailty. Okay, next slide, please. So some of the first manifestations of frailty include weakness, slowness of walking speed, and decreased physical activity. So it's important to consider frailty as part of your differential diagnosis. If you're in the clinical setting, there's obviously other reasons why this can occur. So the weakness can be associated with inflammatory conditions like a flare-up of rheumatoid arthritis. A lot of times polymyalgia rheumatica is manifested by overall weakness. That's why sometimes I get a SED rate or, look at the C-reactive protein for what I consider generalized inflammatory conditions. It can be associated with changes in lung and heart function. So somebody may have had a silent MI and they're talking about getting short-winded when they walk up the stairs, which never happened before. So you have to really put on your thinking cap as to what all the potential etiologies might be, including side effects from medications, right? So if somebody's on 5 or more medications, you have to start thinking about adverse events or drug effects that are associated with that medication. Next slide, please. So there is a differential diagnosis for each of these, right? So that's what I was talking about, is that for weight loss, you have to think about cancer. And I'm not sure that in an 85-year-old that would be my first, worry. I would worry more about failure to thrive syndrome before I would think about cancer. But things like apathetic hyperthyroidism, could be an endocrine, where you get too much thyroid being produced, but it kind of manifests itself as weakness in the older adult, is a common syndrome. And again, just the emphasis on the medications. The fatigue, sometimes if people are on steroids, prednisone before, and they're withdrawn, you might get adrenal insufficiency. But I think the big one for fatigue and generalized weakness is to think of obstructive sleep apnea. So we're prescribing an awful lot of sleep studies to catch up on it. I was actually involved in as a medical consultant for litigation about a individual who fell asleep at the wheel while driving and wound up unfortunately killing somebody. And the lawsuit was based upon the lack of the provider not recognizing obstructive sleep apnea and narcolepsy. Okay, next slide, please. So this is, again, just emphasizes the frailty as a physiologic concept. I don't want to spend a whole lot of time on the, because this is a lot of theory and research, but as you can see, these are all different cycles that from a clinical point of view, at the very top here, you can see decreased motor performance and slow walking. So that's what we can recognize, right? We see somebody coming into the clinic that's moving slowly. If we formally measure it, like they do in my clinic at Sanford Internal Medicine at South Point, then that person with 1 meter per second or less is considered at risk for falls and may get referred to our geriatric programs. Next slide, please. So in terms of primary frailty, there's different reasons that I've alluded to. First one is inflammatory changes. So these individuals, when they measure their blood, they have increased levels of IL-6. Their C-reactive protein as an inflammatory marker is usually elevated. They also happen to have decreased immune function, which in these days with the pandemic is an important consideration. They may have unexplained anemia. Usually it's around 10 to 11 grams of hemoglobin. They'll have elevated hemoglobin A1C. If they measure other things like insulin growth factor 1, those are going to be low. They tend to have higher levels of cortisol, indicating that the body's under some form of stress. Low testosterone for both men and women. And I tell my older adult men, if they start weightlifting, that they can regain their testosterone levels to their youthful 40 to 50 years of age. They all smile and like that. And they say, well, why can't you just give me a pill? And I say, well, because the pill doesn't work. And there's a variety of other observations that we can see with what we call the primary frailty. Remember, primary frailty is not associated with any particular disease, where secondary frailty is associated with heart failure and COPD and so forth. Okay, next slide, please. So the frailty phenotype, I put Freddie Mercury here. He became quite frail in his final years of life. As you listen to Queen, which is my morning wake up music, as a disclosure also. But as I mentioned, these chronic infections like TB has a wasting disease, heart failure, HIV. It remains to be seen whether COVID has anything similarly to this. I mean, they're now identifying out of some of the British studies that 1 out of 3 older adults who had COVID have some sort of cognitive dysfunction, either due to mood or memory changes. And so that's pretty disheartening. And hopefully it's transient and not permanent. Okay, next slide. Yes. So why would you want to screen for frailty? I think we've kind of talked a little bit about the importance of it. So you do want to identify the risk. You want to measure how severe the frailty is so that you can figure out whether it's a preventable or treatable situation. And then ultimately, you want to see if your treatments are working. So you want to see if there's changes in functional status over time. as opposed to perhaps the discussion should be more along the lines of palliative care transitions. Next slide, please. So there's a variety of ways to assess frailty. I'm a fan of the Fried scale, but there is a rapid screening scale called the Frail scale from, I believe, St. Louis University, as well as this clinical global impression of change. And then my absolute favorite, I happen to put at the bottom, probably should keep this at the top, is walking speed or grip strength. So we're actually looking with a collaborator out of NDSU, who is, even though he's a Bison fan, is looking at what we call digital grip strength. And we're looking at whether this is as high of a predictor as walking speed is for frailty and loss of functionality. And what the digital grip strength allows us to do is to measure velocity, wobble effect, endurance, as well as strength itself. And so we think that those extra measurements are going to help us refine or fine tune our evaluation of the older adult who's on a trajectory towards frailty. Okay, next slide, please. Yeah, so this is the Frail scale. You can see the rating there, 0. So if you score nothing on any of these, you're A-OK for the most part. But you assign 1 point for these. So if they have manifest fatigue, so if they report they can't get up one flight of stairs without stopping. Of course, in my differential diagnosis, I start thinking of polymyalgia rheumatica right away, but this is often associated with frailty. Inability to walk 1 block without stopping. And then remember we talked about greater than 5 chronic illnesses, and then also loss of weight. So that's the Frail scale. It's pretty straightforward, and it's a good mnemonic. Next slide, please. So I want to turn now towards the strategies for managing frailty. And so basically, comprehensive geriatric assessment is the way to go. I mean, that would, I guess, be the gold standard. Certainly in the state of North Dakota, I think there's only one comprehensive geriatric assessment program in the state, as far as I'm aware of. So, the resources are not plentiful by any stretch. And so it really is important for all of us to think about ways that we can produce geriatric assessment, either as a team-based program or integrating that into primary care would be, I think, a very aspirational concept. And that's part of the intent of these presentations, is to think about how we can incorporate comprehensive geriatric assessment. So when you see somebody, how do you know they have polypharmacy? Well, if they have 5 or more medications, they've got polypharmacy. And so that should be a referral to the PharmD to further evaluate and make recommendations. If they have a history of falls, certainly that's an indicator that they'll have a future fall. If they're with an assistive device, or if they happen to not be able to stand 1 foot in front of the other for more than 15 seconds, they're going to be a high risk for falls. So that's another way that we can evaluate that. In terms of functional status, we look at things like their ability to shop, get around, their transportation, do they pay their bills, and so forth, to measure any impairments in functional status. And then we measure mood, so we look at things like the PHQ-2 test, which is a screening for depression. We may look at something like the GAD-7 for anxiety measurement. And of course, we use the mini-cog for cognitive impairment. Next slide, please. So here's some of the strategies that we want to look at for managing frailty. Firstly, you want to look for secondary causes of frailty. So things like what I mentioned, hyper or hypothyroidism. So we might get a TSH, for example. There might be an electrolyte deficiency, right? So there might be a low magnesium. Saw a lady just the other day in clinic had low magnesium levels. Not quite sure why, but that could be a source of her overall weakness. So some of these secondary causes of frailty might be things like unresolved grief. So you always have to watch for the older adult who's lost a spouse recently. And then there might be other things that will help us think about frailty, such as what do they do for their mobility? Are they getting around? If somebody tells you, yeah, I used to walk a lot, but now it's just whatever I do in the house or the apartment. That change and decrease in physical activity, of course, it's occurred during the pandemic, is also a precursor to frailty syndrome. And then the other part that we want to manage is what we call the vulnerability. And so, like, who's your go-to person? So I always ask the patient, if you got in trouble, like, if you got really sick, who would you call? And I document that. I get that person's name and I put their number down in the chart if it's not already recorded in the electronic medical record. So all of that's really important, because in these individuals, once you've decided yeah, they've got frailty, you want to do everything you can to keep them out of the hospital, because they really, once they get in the hospital, bad things happen. And I can't tell you repeatedly how many stories I can share with you, case reports of frail older adults that go into the hospital, and if they survive, don't do so well, right? So their post-hospitalization is really quite miserable and not a very good experience for them. Next slide, please. So some additional strategies for managing frailty is that we want to really elevate adaptations, right? So we want to get their goals. That's why in the geriatric 4Ms we talk about what matters. Okay, so if somebody says taking care of my grandchildren, that might be important. But then if we did a mini cog test, or then later, if it's screened positive, they only got 3 out of the 5 responses for the mini cog, and then we do a slums test and find out that they've got an 18 out of 30 score, we might think, well, we're going to have to take care of your memory, and if we can reverse that, then maybe taking care of your grandchildren is going to work out just fine. But then on the other hand, maybe you shouldn't be driving the grandchildren around because we've got this cognition issue and so forth. So you can see how the screening process really now impacts intergenerational questions. And I've always sort of joshed around with my colleagues in pediatrics, and I said, would you be able to recognize a cognitively impaired grandparent? And of course, that just starts turning the gears for them to think about it. So yes, geriatrics does interface with pediatrics in some manner. And so just getting back to the functional support for the older adult, there are a variety of things, that we recognize. Meal on Wheels, part of the reason for transitioning to assisted living, maybe because of these functional impairments. If you can afford it, a home companion. Some more affluent families can afford 24/7 care, or some other iterations of that if they are living at home with the older adult. I've prescribed a personal trainer for an older adult who is having a lot of pain, and just through increasing physical activity, sort of that concept, no pain, no gain, that the personal trainers actually were quite beneficial. And then the final point there is to compensate for diminished competencies. So again, whatever the deficit is, what are the things that you can put into place for supporting it? And for everybody, it's going to be a little bit different. So some of these folks, they just needed just a little bit of touch of support. And for others, they need total support. So that's why it's good to involve occupational therapists and physical therapists in this process for doing those evaluations and informing the clinician as to what they need, and as well the social worker. Next slide, please. So I want to turn a little bit to the prevention of frailty. So the biggest one is immobility. And so if you're a couch potato, you're going to become frail. Actually, no matter what your age might be. But I'm recalling the whole story about Howard Hughes the famous billionaire who really became decrepit because he just basically lost the will to live and just didn't get around, just sat around all the time, and he became very, very frail as a consequence of that. There's also this issue of depression, which can be associated with decreased activity. Just the inactivity increases inflammation, and so it feeds that cycle again of the inflammation causes fatigue, weakness, lack of desire and interest in things. And so that can be also a underlying component to think about in this frailty prevention. Now, mind you, some people, and I mentioned earlier on an earlier presentation, how do I want to say it, the explosion of antidepressants here in North Dakota, that so many patients I see have 3 antidepressants being prescribed to them. And I said, my God, if one can't do it, how can 3 do better? I don't know. If anybody can explain that to me, I'd be really like to be informed. But these 3 medications, these 3 SSRIs, if they're on trazodone and they're on mirtazapine and then they're on Zoloft or sertraline, they all add up together and just cause side effects, right? And so it could be very well that you've got medication-induced frailty syndrome. Next slide, please. Okay, so just this is pretty much not much works. They were trying to use androgen replacement therapy. Remember, therapy rather. I was talking about testosterone supplementation. People have used DHEA, which is a precursor to testosterone, and it's true. Testosterone goes down both in men and women, but none of the studies for those androgenic replacements have really worked. I'm real interested in seeing how things turn out with what we call bioenergetic interventions. I prescribe what's called nicotinamide riboside, or NAD. It's a precursor, energy precursor. I have not seen any studies, at least in humans, that have shown that it's effective in frailty. It's mostly on what we call preclinical models, where aging mice benefit from this supplement. And so I just put that out there as a possibility. And I use that disclosure to patients. I say I have no clue if it's going to work, but this addresses your energy production. In terms of anti-inflammation, so if people have generalized achiness, as well as weakness associated with let's say a low-grade inflammatory osteoarthritis, I tend to look towards Tylenol scheduled on a regular basis so they can start getting over the hump of that painfulness, if you will. And also I'm a big advocate of regular twice-a-day turmeric, which has anti-inflammatory capabilities. And Dr. Minocha will be happy to give you any turmeric recipes that she has to make it a little bit more palatable, because a lot of people just don't like taking the pill, and they tend to be expensive. So sometimes the dietary intake is, I think, a little bit more preferred. And then the final point here is to get rid of the medications, right? I mean, if you're on 5 or more medications, you have a 90% or better chance of having a drug-drug interaction. And then guess what? The provider, the physician, or whomever, nurse practitioner will say, oh, yes, we're going to treat your diarrhea with the slow modal. It's anticholinergic and it's going to get rid of your diarrhea, but then it just covers up the symptoms because the diarrhea is being induced by Aricept or some other medication. So it's kind of like the dog chasing its tail. Next slide, please. In terms of frailty prevention, really got to emphasize physical activity and resistance training. The second point is just really, really important. So you need minimally twice weekly resistance training. And I wish I practiced what I preach, but you gotta pump the iron or squeeze the stretchy bands, and that's vital, for increasing lean body mass. The other forms of exercise, which include aerobics don't help as much as resistance training. So if there's a pecking order, get them going on the resistance training, and then move to aerobics. And some people in these research programs will prehab or get people going on resistance training and then move to endurance training or aerobic training. And a lot of times, most of the studies in the past have been just the opposite. In terms of preventing immobility, my recent prescription is to have people stand up and sit down in their chair like this lady, even though it looks like she's kind of nodding out and snoozing. This lady, if she's watching TV, I would say with each commercial break, I want you to stand up and sit down 5 times. So that's my new prescription in the clinic. Next slide, please. Some evidence that the Mediterranean diet, so high in fish, vegetables, grains, and fruits can help prevent frailty. So there's one study. The protein supplements, proteins can be lentils and so forth. And then nutritional supplements, hard to say whether they work or not, but they need to be matched up with exercise. So increasing physical activity in association with nutrition, I think is important. I don't have a lot of information on the keto diet. I don't think the keto diets prevent frailty, and there's a lot of controversy about that. I mean, my gosh, with the keto diet, how many avocados can you eat before you go crazy, right? I mean, you turn into a guacamole head. So, all right, next slide, please. So then there's this overlap, of frailty and failure to thrive syndrome. So when do you say somebody has adult failure to thrive syndrome? And basically, I think it is frailty where it has the most severe end-stage symptoms. And there's some arguments about whether we should use the failure to thrive syndrome just because it has pediatric connotations and people start to, make the older adult look like a childlike syndrome, and it's just really not very, very enhancing. But anyways, there is a overlap between the two. And again, as you can imagine, end-stage heart failure, this concept of failure to thrive, helps clinicians decide that this is an irreversible process, and really it is futile, and you need to let the families and the patient know that there's nothing you can do to make them go back to where they were before. So that's why failure to thrive still has some resonance. Okay, next slide, please. So thinking about palliative care with frailty or end-stage frailty or failure to thrive syndrome is based upon a progressive functional decline, lots of dependency related to end of life. And so you can consider on that frailty score, if somebody scores 4 to 5, remember, did they have weakness? Did they have a slow gait speed? Did they have 5 or more chronic conditions? Once they hit that number 4 or 5, you can really start thinking about hospice and palliative care. Other adjunct measures that I use are cholesterol, albumin, and pre-albumin. Next slide, please. So I just want to summarize and then open it up for some questions or comments, is that we understand frailty as a syndrome. It's physiologically based and it's dysregulated. The homeostasis or that balance is disrupted. It can be seen both at the cellular, immunologic levels. And we have tools, so that, remember the Frail tool or the Freed index. And so basically all those things that you put in the beginning when we asked, everybody hit it right on target here. It's weakness, slow gait, low physical activity, feeling of exhaustion, and weight loss. So I really appreciate your insight on that. I think we all know, how to recognize it. And the question now, I think, really is how to best tackle the syndrome, either in a preventive manner or through intervention, or then thirdly, once as I say, the cat's out of the bag, through palliative care. And it's rare, when our geriatric fellows do their hospice and palliative care rotation, they very rarely see failure to thrive as the primary diagnosis. So I think it's underutilized. as a measure for activating palliative care, but it's something that I think we should all keep in mind. And if you do have an opportunity to make those kinds of recommendations to the primary care provider, I think it would be a service well done.